Greetings. I'm Patricia Ricketts, Vice President of Programs for the Greater Harlem Chamber of Commerce and co-chair of the Chamber's Health Committee. On behalf of the boards of directors of the Greater Harlem Chamber of Commerce and Harlem Week, I'm pleased to welcome you to our COVID-19 Summit presented by the Chamber and the City College of New York. The summit will explore the disproportionate impact of COVID-19 on communities of color. What happened, where we are now, and where do we go from here? We'll begin with remarks from Honorable Mark Levine, New York City Council member and chair of the Council's Committee on Health, followed by Dr. Alsuma Fergus, Associate Professor of Medicine and Director of Cardiovascular Disparities, Mount Sinai School of Medicine, followed by Dr. Maurice Wright, Medical Director of Harlem Hospital Center, joined by his colleague, Dr. Kamoy Wanglama.
Hi everybody, I'm Mark Levine, New York City Council member, representing the 7th District in Northern Manhattan, and chair of the City Council's Health Committee. And I want to thank the Greater Harlem Chamber of Commerce for inviting me again this year to be part of the program. I look forward to Harlem Week every year. It's not the same not being with all of you in person, but nonetheless, an important week, a great event to celebrate uptown. And I'm pleased that you're once again focusing on healthcare, and particularly this horrible pandemic, which is an ongoing crisis for uptown, for New York City and beyond, and which has exposed incredible inequalities for our city, painful inequalities that are the results not just of inequality in recent months, but of years and generations. The numbers are really stark. In fact, the fatality rate from the coronavirus for African-American New Yorkers is double that of white New Yorkers. And if you look at the numbers on a neighborhood level, on a zip code by zip code level, it's even more dramatic. Here uptown, in the zip codes of Harlem and nearby neighborhoods, the fatality rate is 5 times what it is relative to wealthier and whiter areas. And it's as much as 10 or 15 times greater if you go to some of the black and brown neighborhoods of the outer boroughs. And this has been a long time coming because of inequalities in our society on every front, including housing, because we know this virus spreads more easily in crowded homes. And that's unfortunately the nature of our housing stock here uptown. This inequality has been driven by employment patterns because it's essential workers who have been out there in contact with the public, performing vital services throughout this crisis, but have also been exposed. And that is disproportionately people of color, and that's driven higher rates of the coronavirus among the ranks of those essential workers. And of course, it's inequality in healthcare, which is really an unconscionable problem in this city and this society, which has led to unequal rates of some of the underlying conditions like diabetes and hypertension, which we know make people more vulnerable to this virus. This is a problem not only to look back on, but this is a problem going forward because this pandemic is not over. We are still seeing about 350 new cases every single day in the 5 boroughs. That number for the last couple of weeks at least has been rising, particularly among young people. We're seeing many cases, about 1/5 of the cases are people who've come from out of state, come from states where the virus is much more prevalent. And that's certainly a trend which threatens us. And as the weather gets cooler and people are going to be forced back inside, there's real concern that we could have a rebound. So we cannot stop fighting against the inequalities of this pandemic by working for greater access to healthcare, to testing, to isolating, to all the support systems that people need. And we can't stop fighting about over inequality in employment and healthcare and housing on the long-term basis. A lot of work to do ahead. I know that the Harlem Chamber is deeply committed to that all of you as part of this program are deeply committed to fighting those inequalities. As your partner in the City Council, as chair of the Health Committee, I'm in for this fight as long as it takes. And I want to thank all of you for what you're doing on behalf of healthcare uptown, in Harlem, citywide, worldwide, for people who have been so unfairly impacted during this difficult time. Thank you again for having me as part of this program, and I hope you all stay safe.
Greetings. I am Dr. Isilma Fergus, Associate Professor of Medicine and Director of Cardiovascular Disparities at Mount Sinai. It's very important to recognize that this very important disease has these underlying ramifications, and so I'm so pleased to be part of this program by the Greater Harlem Chamber of Commerce. I will present my information by sharing some slides with you. So let's just bring up these slides. So what is COVID? COVID-19 is a coronavirus that was discovered in Wuhan, China in 2019. This virus affects humans by getting into their membranes and causing primarily a respiratory illness that affects lungs and airways. But as we discovered, and as I will point out, many other organs can be affected. If you compare COVID with the flu, COVID is far more contagious, 2 to 2.5 times compared to 1.3 with the flu. It sickens you for a longer period of time, 2 to 14 days, compared with only 1 to 4 days for the flu. 19% of people tend to be hospitalized because of the various organ involvement, compared with 2%, and up to 3% or more of patients with COVID are more likely to die, compared with less than 1% for the flu. And of course, as it relates to health inequities and people of color, brown or black, that mortality may be higher. So what are the symptoms of COVID-19? Symptoms can develop up to 2 to 14 days after the exposure to the virus, and you may have no symptoms at all, or you may have some of these symptoms as outlined here. Cardinal symptoms may be fever, chills, cough, shortness of breath, or fatigue. But we recognize that many other symptoms can occur, including aches, pain, headaches, and the newly evaluated loss of taste or smell, known as anosmia and ageusia. Of course, you can also have symptoms of a common cold. Added recently in June were the GI types of symptoms with nausea, vomiting, and diarrhea. When do you know that this is an emergency? Is when you have trouble breathing to the point where your oxygen levels drop below 90%. You can measure that with a pulse oximeter. If you get chest pain, of course, you may be thinking that this is related to the heart, irregular heartbeat related to the heart. Your face becomes, or lips become bluish. That means low oxygen or new confusion, inability to sleep or stay awake. These are emergency symptoms, and you should get to the hospital right away. I'm going to jump right in and talk about why African Americans, in fact, Black and brown people, likely to be affected most. And this has a lot to do with the longstanding systemic health and social inequities that are facing us in the United States today. And this, of course, put members of certain racial and ethnic minority groups at a higher risk of many chronic conditions, including COVID-19. So besides talking about the underlying conditions, which I will focus on for a little bit, we have to recognize that sometimes we're looking for the causes in all the wrong places as to why these things happen. And so we need to look at the social and structural determinants of health. And these are those factors that actually play a major role on why people are sicker. So basically, it's where one lives, who they are, their socioeconomic status, their sexual orientation at times, their gender, whether it is disabled, and any type of combination. And this relates to a health disparity. Health inequity relates to this, and it's a difference in health status between different groups within a particular country that are systematic and unjust. That's an inequity. The equity is obviously the opportunity to attain the full health potential where no one is disadvantaged and because everyone is available at the same level in terms of access. So these social determinants of health I just talked about are things that we need to overcome in order to really get to appropriate health equity and to reduce racism and bias as it relates to health. And especially with COVID, this is an important thing to do. Notwithstanding, there are certain underlying conditions that, of course, have to be dealt with and recognized. So we know that there are multiple underlying conditions which can make people more susceptible to COVID, including chronic lung conditions, chronic kidney conditions, diabetes, obesity. But I submit to you, hypertension is among one of the most likely conditions to cause poor outcomes in patients with COVID. And in a number of anatomical studies have been present in up to 70% of people who died from COVID. In Wuhan, China, this was shown, and also here in the United States, a number of different studies have already shown that. And in this slide, you could see that Black males and females over time have continued to lead the pack in terms of hypertension. And so it's a particular concern among this group. So again, dealing with those issues that, cause, make you more susceptible, if you will, to the COVID. Now, I'm a cardiologist, so of course I will focus on COVID-19 and the heart. And again, the Black and brown patients are more likely to succumb to these types of issues that I will point out. So you can get a heart attack from a clot that's known as a thrombus or an embolus that will block your artery or break down a vulnerable plaque relating to or leading to heart attacks. Myopericarditis is the inflammation around the heart or in the heart muscle known as pericardium or myocardium. And then the cardiomyopathy is where the heart stops working, leading to congestive heart failure. Along with that, I have seen a lot of Black and brown patients that present with an irregular heartbeat known as an arrhythmia, in particular atrial fibrillation, which is related to the COVID-19. So what are some of the treatments? Well, we want to make sure, of course, that the treatments are applicable and related to our Black and brown patients, but recognize that as of right now, there are no really indicated outpatient medications. I want to restate none. Hydroxychloroquine has been touted as an effective treatment. Hydroxychloroquine is effective in many conditions, but has not been shown in multiple trials and multiple studies to be effective for COVID. Hydroxychloroquine is effective for malaria, it's effective for certain types of arthritis and lupus, but in COVID-19, the majority of the studies have shown that not only is it ineffective, but it may cause conditions related to the heart, such as arrhythmia, and damage to kidneys and lead to sudden cardiac death. And the patients who most likely will then receive it because they may not be aware of some of these, adverse outcomes, maybe Black and brown. Steroids, dexamethasone in particular, have been shown in the hospital to be beneficial. Blood thinners, including heparin and the dual oral anticoagulants such as apixaban, have been used in patients to break up the clots and to also treat patients with arrhythmia such as AFib when they leave. Some of these medications, such as the DOACs, can be quite expensive. And of course, so the Black and brown individuals will have a harder time procuring these treatments when they leave the hospital. Within the hospital, the plasma or antibody infusion and anti-cytokine interleukins have been also beneficial to help. So what can Black and brown people do is build your immune system. Build your immune system. In this next slide, I talk about how can you protect yourself. Educate yourself using reliable sources. So if you're hearing certain things that just don't gel, don't listen to them. Listen to the Greater Harlem Chamber of Commerce, who puts out a lot of important information, or find other sources that are reliable because it could be critical to your life. okay? Especially if you're Black and brown, for the numerous things we talked about before, including some of the underlying conditions that may be there. We talk about being able to boost your system. I just mentioned eating healthy foods, including vitamin C, D, exercise, rest, get a mental wellness, stress reduction checkup. And what can you do physically for yourself and your family? Cover your mouth and nose, wear a mask. Okay, these droplets spread, and you have to be within 6 feet away because they will spread going to your mucous membranes, and then you get infected. Wash your hands often, use soap and water. If you can't, then use a hand sanitizer and avoid close contact. Community education, vastly very important. So symposia such as this, very important. I founded a program called the Healthy Heart Series, of which one arm was the Harlem Healthy Hearts, and we provide monthly workshops. And here are some of the resources that we use to educate. So managing hypertension, diabetes, speaking to little children about coronavirus and explaining it, because as you know, they may be asymptomatic carriers. And of course, how do you cook healthily to protect your body? And so I want to end with this one slide that punctuates everything that we're talking about. Equality, equity, reality, liberation. Equality is everyone being given the same box, but the little guy, who are often the Black and brown people, still cannot see over the fence, and the big guy who doesn't need the box is way above where he needs to be seen. Equity is taking the box from the big guy, giving it to the little guy. Now they can all see over the fence and interact and be able to enjoy. This is where we're aiming to get, but we're a long way from that. What happens in reality is that that big guy has 6 times the amount of boxes than anyone else, and the little guy is often dug into the ground. So we want to get to equity, but the optimal thing would be liberation, where there is no wall and everyone can enjoy as they should. So when it comes to COVID-19, it's being able to provide everything that needs to be done to the Black and brown individuals and patients, such that their immune system is built, that they're having access, that they're getting care, that they manage their underlying conditions, and to overcome this very terrible pandemic of COVID-19.
Welcome to the COVID-19 Summit, put on by the Harlem Chamber of Commerce. And we are going to talk today about the disproportionate impact of this pandemic on communities of color. I'm Dr. Maurice Wright, Chief Medical Officer at New York City Health and Hospitals Harlem, otherwise known as Harlem Hospital. This pandemic has caused unbelievable or impacted us in an unbelievable way. So welcome. It's a day where not only do we get to think about where we are, but it is also a day when we get to reflect so far. It has affected our community and community like ours in unbelievable ways. Community members, inhabitants greater than age 25, but especially greater than age 65, has taken a huge, huge hit in terms of morbidity and mortality. When we look at various groups, ethnic groups within this community of color, we see that Hispanics has a huge disproportionate outcome in the morbidity and mortality area, followed by African Americans, followed by Asians, and then whites. When you look at the various diseases that we have in our community, hypertension, diabetes, hyperlipidemia, coronary artery disease or heart disease, respiratory disease, kidney disease, and obesity. These are comorbid conditions rampant in our community that we are trying to address, but that seems to be linked to this pandemic in unbelievable ways. These are the people who most likely suffered and is suffering from the disease in huge numbers. Those who had one or more of these comorbidities, but especially greater than two, and the more seems to add on to its impact, suffered the most. Those who arrived and went straight to an ICU seem to have done worse also. When we look at the mental health aspect, I can tell you that even the healthcare professionals on the front line, and especially those of us that live in the community, seems to be suffering the long-term effect mentally, if not physically. And it is a true outcome of this pandemic. Now, over the last 10 years, I've been a chief medical officer at Harlem Hospital, and I've spent my time helping to design systems that are effective to deliver care. When I was in medical school over 30 years ago, I remember the lecture when in infectious diseases they talk about one day we will see the 1980 pandemic. And I used to shrug it off, 1918. And I'm talking about the 1980s. And I say, oh, I'll be long gone. A lot of people have come and gone and there wasn't a pandemic. Little did I know that I would be in the middle of one. In helping to design a system which is reflective of the care we deliver, no one could have imagined this. And so you can imagine, yes, we have a system. That system was stretched beyond belief. And you hear a little bit more of that when especially Dr. Wang Lama speaks to you. In designing any system to respond to healthcare emergencies, you need the help of the community. You need the help of the elected officials, and of course, intimately the help of your colleagues around the nation. We saw a tremendous, tremendous response. So I can talk about the fact that the hospital expanded rapidly to accommodate many more patients than our staff had seen, at least in my time there. And then you can imagine in expanding that facility, we needed staff. And we were able to see others come in to help us. The military. I want to give a big shout out to them. I want to give a big shout out to the other healthcare professionals that poured in from around the country to come and help us. I remember thinking that it would take about 3 weeks after it started on the West Coast before it got to the East Coast. Little did I know it was right here already. And one day, March 16, the floodgates opened up on our community. It has been quite a journey. Professionally, I responded as expected. Do the most you can with the resources you have for all that you can. Little did I know that I would come down with the disease also. Little did I know that in taking care of others and doing the best not to get the disease, that I would become afflicted by it. Thank God, I can say that my journey was an easy one with the virus. A day of fever, 3 days of back pain, and I guess all the prayers that went up, I didn't have much to complain about. But I did see its effect in an unbelievable way on my brothers, sisters, mothers and fathers in this community. So I thank the Harlem Chamber of Commerce for getting us all together for this summit. I look forward to hearing what each and every one of our panelists have to say in their area of expertise. And I want to encourage all that are viewing this to remember that some of the rules are pretty simple. Let's follow them. Face shield, hand washing, be distant from those other folks around you when possible. And please, please do not become silent to others in carrying out that mission. Thank you. Thank you again to the Chamber of Commerce and all the panelists who will be part of this great summit. Thank you. Dr. Wang Lama, and let me just say, I have known Kim Wai for many years, but I saw a new side of her through this pandemic. Born and raised in Ecuador, and she completed her medical school in her native country, trained in internal medicine at Jacobi Medical Center in New York, completed her pulmonary and critical care fellowship at Northwell North Shore, Long Island Jewish Hospital, and joined Harlem as pulmonary critical care faculty in the Department of Medicine in 2014, and transitioned to Director of Critical Care in 2018. I can tell you her work on the front line was exemplary. She led us and led those various teams as they expanded, and produced the very good to great outcomes that we had at the hospital. Dr. Wang Lama.
Good day. My name is Dr. Kimoy Wong Nama. I'm one of the pulmonary critical care doctors at Harlem Hospital, and I'm going to be sharing a little bit of our experience at Harlem Hospital during the COVID-19 pandemic. Harlem Hospital was in the center of the New York City COVID-19 2019 outbreak. Harlem Hospital serves a large community in Harlem that was affected disproportionate by COVID-19. We saw a rapid increase in the number of patients and the number of cases, with a very fast, severely rising acuity of illness that affected our hospital and our community in an unprecedented manner. In order to accommodate to the rapid increase of patients and acuity, Harlem critical care units had to triple their capacity. The number of beds available in the medicine and surgical floors had to double as well in order to accommodate the rapid influx of patients through the ER. This had to occur in a matter of hours and days. The number of mechanical ventilators available in the hospital were always sufficient, but we have to rise from usually using 10 ventilators a day to using 4 or more ventilators a day in less than 5 days. At times, it was considered that the emergency department, the medicine and the surgical floors, as well as some of our surgical spaces or outside the operator rooms, were small or satellite invasive intensive care units that were supporting the rapid increase of patients. We witnessed a very rapid and disproportionate increase in cases affecting young male adults. These patients rapidly flooded our units, as well in the critical care units and on the floors, with severe respiratory distress and illnesses that require most of the time invasive mechanical ventilation. Most of our patients were African American and Hispanic. The rapid increase of patients was only matched with a quick fire of medical literature that was coming from countries outside of the United States that had been facing the same clinical challenges for several weeks prior to us, predominantly from China and Italy. It was quite challenging to incorporate the literature coming from outside with the resources we had available in order to support the patients with all the resources we had and we could obtain to increase the chances of survival from this devastating illness. We were able to accommodate that in Harlem with the support of H&H and the support of healthcare community that came from outside our city. Nurses, physicians, and the military that came to quickly support the rapid rise in patients and the necessity we had at Harlem. In the critical care units, the large number of patients, combined with the limitation of visiting hours and the rapid unprecedented loss, was very difficult. not only for us, but predominantly for the family members and the patients that were not able to see their families. It was difficult to communicate with family members. It was difficult to help them understand the severity of the illness, but we did great efforts with video support and with teleconference in order for them to maintain communication. The aftermath of this different type of healthcare system and healthcare providing system that we had to provide to our patients, it's still something that we try to overcome as a healthcare community and as a community as a whole. The community, the hospital team, including physicians, nursing, leadership, and all the essential providers, continue to support each other while facing the unprecedented losses as we remain alert and prepared to face the months to come. Harlem Hospital had to increase their capacity and raise the number of patients and capacity of ventilators in numbers of days and weeks. We are ready to do this again if we have to, although we hope that we don't have to do it again. The community that we serve is still recovering from what we went through. Although the number of cases are not high right now in the community, the aftermath that the patients and our families had to recover from is still very, very significant. And that's some of the topics that are going to be discussed later in this summit. Thank you very much for your time.
It is my honor to introduce our moderator, Dr. John Palmer of John Palmer Associates. Dr. Palmer is a renowned clinical psychologist. He's a member of the Executive Committee of the Board of Directors of the Greater Harlem Chamber of Commerce, and John serves as co-chair on the Chamber's Health Committee.
Thank you for coming. Welcome. Welcome to the COVID-19 Summit, sponsored by the Greater Harlem Chamber of Commerce and the City College of New York. Hello, my name is John Palmer. I'm here with the disparities segment of our COVID-19 Health Summit. My guests today are Dr. Mesa Aze, Associate Professor in Microbiology at the Touro College of Osteopathic Medicine in Harlem. Dr. Aze received her education in Germany, where she also started her academic career. She then worked in Israel and Palestine. She established the first Palestinian virology research lab in Palestine. There she studied and published data on generic epidemiology and vaccine efficacy of clinically critical viruses such as influenza and hepatitis B and C viruses among Palestinians, also an understudied population. In addition to Dr. Aze, we have Padmore John, a manager for the Bureau of the Harlem Neighborhood Health Department of Health and Mental Health, New York City. Padmore has worked in public health and emergency preparedness in New York City over the past 20 years. His primary focus is on addressing health equity by understanding the health impact of structural racism and building partnerships to create place-based solutions. He lives in Harlem with his wife and 2 children. Before we get started with this very, very smart panel, I'd like to say that it's been a pleasure working with both of them over the last 6 months, and I've learned a lot more than I expected to learn. And I want to say today, while they're going to talk about disparities, they're only going to touch it with a light brush because it's a very, very deep subject intertwined with racism and years of discrimination in this country. So remember, this is very deep. You'll certainly be tasks to deal with the statistics, but their way of explaining this and bringing it home, I think, will clarify any issues you have before we're over, and I certainly would help to do that as well. So without further ado, Padmore John.
Thank you, Dr. Palmer. It's a pleasure to be here with you today, Dr. Aze. And I appreciate the introduction, Dr. Palmer, specifically where you were speaking about the influence and the consequences, the health consequences of racism and racial injustice And that was specifically made out by Dr. Ayman Almanhandis of the City University of New York, the School for Public Health. And so our first slide speaks to that. This slide shows what has been happening in our neighborhoods prior to COVID-19. And there are very specific places, as you would see in the slide, the darker red areas indicate where there is a high incidence of premature mortality, as well as infant mortality in very specific neighborhoods. And many of these neighborhoods are the prime areas that we have seen some of the larger amounts of death that has occurred, specifically in communities of color, for African American and Hispanic populations. And so, for example, we are seeing that there were high incidences of obesity and diabetes rates that occurred for quite some time prior to COVID-19, to some extent because of lack of access to nutritional foods, food deserts, or certain type of restaurants that are in closer proximity to where individuals live, and it's easier for them to access this type of food. So that was almost a precursor that somewhat underlines many of the complications that we have been seeing that COVID-19 has taken advantage of. So I just think that it's a good space for us to begin, for us to frame what has occurred prior to COVID-19, and to recognize that, as Dr. Palmer said, there's structural racism that has limited the abilities of individuals to have access to resources, disinvestment in certain communities that have pretty much left many of these community individuals, residents, at risk of what we are going to be seeing in COVID-19. Dr. Aze, if you want to look at some of the numbers that speak to that.
So when we, first I would like to thank Dr. Palmer for this nice introduction and for this opportunity to talk to you about what the numbers have been telling us so far. So initially we only had the numbers from the viral testing, people who were acutely infected. And if we looked at the numbers provided by the New York City Health Department, we could see that the numbers of cases, infected people, hospitalizations, and death rates had been highest among the Black African and the Latino Hispanic communities. And what really struck us that that was throughout the different age groups, starting with age 18 up to 75. All along, we had seen higher numbers of death rates, unfortunately. And if we look at the total number of death rates between the different groups, we could see, and we could go back to the population, thinking that, for example, the white population is around 3.7 million people, while the Black is around 2 million people. In both cases, we had around 5,000 deaths. So this means there is double rate of deaths among Black people. But a surprise came back when actually we started doing the antibody testing. And that actually is not, I'm not telling you this to relax you, I'm telling you this to realize that what Padma was talking about right now is really very essential. Now, more and more publications, scientific publications, even if you go to the CDC website, they will address risk factors. Among risk factors, health disparities, discriminations, poor neighborhoods, crowdings, even in regular reports in newspapers. And that explains the numbers which came from the governor when he presented the percentages of the antibody testing, positive antibody testing against COVID-19 in the different groups and the different areas of New York City. And we could see that the percentage of antibody positive, the percentage of white people having positive antibodies against COVID-19 was only 6%, but it was 20% among Black people, 30% among Latino Hispanic people, and that is the report of June. So I think now we're going to have higher numbers. And I think yesterday or 2 days ago, there was a report in the New York Times about an area in Queens called Corona. I think there was 68% positive antibody testing. And why is that? It's due to the crowding, the kind of work these people are doing. They're doing essential work, they're in hospitality, they're serving their communities, so they have more exposure to people. So let me just discriminate between two facts here. So one thing is kind of sounds okay, because when you look when we looked at the death numbers, we were really surprised that the death numbers were so high in the Black and Latino communities. But when we looked at the antibody testing, it was a little bit kind of a relief. Why? Because if I have 30% of Latino Hispanic people who saw the infection, were infected based on the antibody testing, this makes the death rates based on this number around only 0.8%, while the white people, for example, who had very low positive antibody testing, tested for at lower rates for antibody, for COVID-19 antibody, then we could say that the death rate had been too high for them. If only 6% were infected and they have 5,000 deaths, this is like 2% death rates. With the Black community, it was 20%, around 20% tested positive for antibody, and then this makes the death rate around 1.2%, almost equal to the Asian community. The highest death rate was actually among white people if we look at the infection rates based on the antibody testing and not only on the viral testing. But this explains actually, and says that when I have a wide number of people infected, the chance for people in these communities to be infected and maybe reinfected is higher because I have a high number of people infected. And reaching herd immunity is still a long way. So we need around 60 to 70% of people infected, and we need these people to maintain infection. Another thing we could be precautious about, and we want people to continue wearing masks, and Padma is gonna try to talk about this a little bit, is that we don't want this disease to spread wider in that direction, because the more spread you have, the more you are actually exposing your beloved ones, older people, people with these risk factors Padma talked about, like obesity and diabetes, to be infected, and these people are gonna suffer from severe infections. And I'm giving it back to you.
Yeah, so one of the quick things we wanted to speak about in reference to testing is to ensure that, and as Dr. Azay said, there are two different types of testing. There's a testing for diagnostic to see whether or not you are positive COVID-19, and then there's also the antiviral testing, whether you may have had it and see it was part of your bloodstream, you may have had it not before even showing any type of symptoms. That is called asymptomatic, but yet still it was within your body, but you just never demonstrated that you were sick or anything like that. So it's important for us to have those two types of testing, and it's specifically more important for anyone who has tested positive that they are able to be part of this test and trace program. The test and trace program, as Dr. Azay was speaking to in terms of the herd immunity, is to ensure that we are knowing who is positive and who they may have gotten in contact with. And that's very important. It builds a large systematic database of knowing where, how individuals are spreading the COVID, how they are being infected, impacted by this, and more importantly is what are the type of resources that they may be able to receive once they have become tested positive. New York City is providing a variety of services, including free hotel rooms, free food, other types of services and resources that will be supportive of any individual that we're able to get to. And so we are also going back into the fact that this high rate of testing around the community, as Dr. Azay said, is, again, essential workers. People are typically in high density areas, high density traffic, high density in subway cars, for example, that may be very full. If you are going out a lot, having to go out because you're unable to stay home at home to be able to do your work. So these are some of the key things that we would like to be able to do and speak about. And then one other component we want to speak about is just what happens next in terms of vaccination. So I'll let Dr. Azay say it.
Yeah. And just to emphasize what Padma said, I really want to point out one important thing. Wearing masks, despite the fact that we know now that higher numbers of people in these communities have been infected, wearing masks is essential for 2 points, and I really want to point this out. Yes, some people had asymptomatic infections, but these people could eventually, if they have partial infection, partial immunity, not full immunity, they may still get infected, not get sick, and pass the virus. So please wear masks first. The second thing is, and this is really very important, that more and more reports, scientific reports, are coming out now saying that those people who had asymptomatic infections were actually exposed to lower dose of viruses. So many studies had shown areas where where people got infected at higher rates, but they were wearing masks, they received very low number of viruses, which we call infectious dose. So they had little infectious dose or inoculum. And so that's why they underwent asymptomatic infection. So please wear masks because this will lower the severity of infections. This is what the studies have been telling us now. And this gets us to the next important point, which is the vaccine. There are like over 150 vaccines now in development. I believe 6 of them are already in clinical trials. I believe 3 of them already, or 2 of them are in 3rd phase of clinical trials. And I believe it is important that all different ethnic groups will be involved in these clinical trials, because we know that there's something we call genetic susceptibility. Some people may develop antibodies and become immune. Others will be less likely to develop antibodies. It could be related to some genetic issues. It could be related to other issues we don't know about. And that's why Padma will address this point in regard to the Black community, because there have been some historical points in why some people, not only average Americans, but why Black people specifically may be hesitant with the vaccine, and then address it back.
Yeah, I mean, just in the sense that it's very important that as vaccine trials are undertaken, that all ethnic groups are included as part of the trials. And we all know that there's a systematic amount of racism that has occurred in terms of medicine and healthcare delivery to African American communities, and as well as other communities of color. So there is a certain amount of mistrust and distrust of within these communities of vaccines and vaccine trials. So it is very important that as the messaging is going out in terms of ensuring that there is a vaccine that can address COVID-19, that there is a message of being able to speak to these ethnic communities, speak to these communities of color, and let them know that it's very important that they are included. There is a great deal of distrust that needs to be cut through, and it's important that that is part of the messaging and ensuring that everyone is participating and that these vaccines are including communities of color to be able to be the most effective.
Yeah, and just one last point is that this is a world without vaccines. So now those people who are against vaccines can see how our lives look like without the vaccine. We need the vaccine. And there are some studies, I'm not really sure they're published yet, who showed that even people with other vaccines were less likely to be infected by COVID vaccine. For example, one study showed that children who had, or people who had the polio vaccine were less likely to be infected by COVID-19. So vaccines are good and they're important, and they're actually the reason why we can actually defend ourselves by antibodies against different diseases.
So at this point in time, we'll be happy to take any questions if there are.
Well, I just want to go back a little bit for you, because it was announced earlier today that Russia has developed the vaccine, and their president has approved it for use in their country. So we're going to very quickly see, or maybe not very quickly, but we're going to see how effective that particular effort has been. And it goes to your point that people are moving more closely to having a weapon that will keep us safer than we are right now, because creating, I think you mentioned, the herd immunity is not working very well. And we're having to really understand the impact of infection on our communities and the way it affects our death rates as well as our continuing infection rates. So that's, as you explained it, very, very complex. So that's one comment I wanted to make. I guess you guys didn't hear about the vaccine, so that's...
I did, but I didn't follow now if they started already, but I know that it's going to be in the market.
Well, they had a picture of him,
yeah.
Putin,
yeah,
with the papers in front of him, so you know it's serious.
Right. I mean, I think one of the key also concerns is ensuring that all the proper steps are taken to be able to bring this vaccine to market, and ensuring that it's as safe, and that's key to find out once it begins going into the population.
Padma, one of the things you said, which is key, is the development, the population you develop the vaccine on. And while Russia has a multicultural population, its population may not be as similar as we'd like it to be to populations around the world. So the usefulness of this vaccine, we'll see how useful it is in Russia, but it may be less useful to us around the world, especially in countries of multicultural
well, the good news
citizens.
is that we are having different type of vaccines being developed, so we're not running behind bloodline. We're using traditional methods, but we use new methods. The one in the US from Moderna, for example, is using RNA, which is really something new, but there had been research going on that for the last 15 years. So this is really good news that we have different lines and different types and different levels of vaccine being developed in different countries. So that's good news that it could be effective against the different ethnic groups, but I do believe that it's important that these different ethnic groups all over the world are part of this vaccine clinical trials to show efficacy all over.
And I think also your presentation clarifies for me the issue of disparities. We think of disparities in the traditional way, meaning a disparity in the kind of health care you're given. This is how disparity was developed. People recognized that black folks were not insurance was not paying for their surgeries. Insurance was not paying for heart surgery. Insurance was not paying for other kinds of artery replacements that would keep people from having amputations if they had diabetic issues. That's where disparity started. But now we see the issue of who's healthier, who's sicker. The African American and Hispanic populations are identified as having disparities because they're defined as being sicker overall. And in fact, being more infected by COVID-19 kind of backs that up, that we're more vulnerable. But you point out that being more vulnerable doesn't necessarily mean you're going to have a more difficult way in dealing with this, or that people who seem to be less vulnerable are going to have an easier way to deal with this. And I think that's important because there's no easy way to get out of this trap of COVID-19. Yeah,
I think that's really important. There is no one brush that can be painted to address all the issues and the different things that we're seeing. Dr. Aze indicated that there are there are constantly new things that are being found out around COVID-19. And what's important about that you mentioned, Dr. Palmer, is that there is a need for us to have very discernible conversations and communication and messaging with those individuals who are most being impacted by COVID, and then create and tailor solutions that is very specific. So it may be different from one community to the next, right next to each other, right? We know that on 96th Street, the Upper East Side and East Harlem is very different communities, right? And so it's important that, and when we're creating a solution that addresses those differences, that is historical, correct? Right. We have seen it for over 20, 30, 40 years in terms of differences that's been coming out in terms of healthcare. And for us to be able to create a solution that is specific to the Upper East Side and then specific to the East Harlem as well, that's important. And it has to be engaged conversation and communication with those impacted communities.
But what I really like, despite the light among all this darkness, is that this wake-up call that everybody is now finally addressing these health disparities being an issue, discrimination being an issue, racism being an issue, contributing to these high infection rates among people of color, Hispanic, Black population.
And then I think the discussion about the mask, it seems at this point a foregone conclusion, but people are still not wearing them. Even people in cities like New York, whose death rate to COVID now is tremendously low compared to what it was, and we're seeing kind of the difference in cities where COVID is spreading like wildfire across this country, where people are totally ignoring social distancing and totally ignoring the use of masks. We certainly hope that people who were able to watch this program and others recognize the need to have masks available and use them properly. Take them on, take them off properly, change them properly. Don't wear them too long. Have a good supply of them available to you and to your friends and family. The lore now of masks is very important to master. So I just wanted to emphasize that is one of the discussion points that you guys brought up.
Yeah. Yeah, I just on that point, and something that Dr. Isaiah alluded to earlier, that there is a difference in the type of mask that you wear. So initially, I think part of the reason that some people may not feel so needed to wear masks is, well, at first no one was saying for the population to wear masks. Well, that was being specifically said so that the mask can be saved and left to essential workers, healthcare workers who were more directly involved in response to COVID-19. And as Dr. Azay said, it prevents the number of the load of viral content that's within the system. The thinner your mask, the less that it will filter out. The thicker, for example, an N95 mask that many of the healthcare workers and healthcare workers will use, that's a little bit better and safer. So it's also wearing the right mask, as you indicated, Dr. Palmer, and making sure that if you are unable to do 6 feet social distancing, continue wearing that mask always.
Okay, I want to thank you very much for coming and helping us with this issue. This is the closing of our disparities segment for our COVID-19 summit. Thank you,
Thank you, Dr. Azay.
Dr. Azay. This is Pat Moore. Thank you very much.
Appreciate it. Thank you.
Hello, my name is John Palmer. I'm here at the COVID-19 Summit for the Greater Harlem Chamber of Commerce. We are continuing our segments. We are now in racism and access. The panelists we have with us are two very distinguished women from their fields of nursing. Dr. Kelly Bryant, Executive Director of Simulation and Assistant Professor at the Helen Fuld Health and Trust Simulation Center at Columbia University. Throughout her career, she's become an expert in the field of simulation through her experience of designing simulation centers, and she's implemented simulation programs for two of the most prestigious nursing schools in the United States. Joining Kelly Bryant, Dr. Bryant, is Michelle Drayton, also a registered nurse, director for hospice and palliative care outreach in Manhattan and the Bronx regions. 25 years of healthcare management experience. She's been featured in numerous media outlets, including WABC TV, Here and Now, Good Day New York, Reader's Digest, Healthy Start, National News, WBLS, WLIB, New York One, and the Harlem Times, and has been published in the book, Helping the Hardcore Smoker Quit. Thank you very much. Please begin.
Thank you, Dr. Palmer. Dr. Bryant, it's so good to be with you and to be at this conference talking about this really important topic of COVID-19 in the African American community in particular, but communities of color. Mm-hmm. And so, talking about social determinants of health and trying to answer the question of why is it that our community is impacted more by this virus. So let's talk a little bit about that. We know where you live, work, play, and go to school mm-hmm. is a major factor in your well-being. What are your thoughts around that? What's going on in our community that's making us more at risk?
There's quite a few thoughts. I mean, when we think about the social determinants of health, first off, we can't talk about that without talking about our access to care. Communities of color, it's been shown that when it comes to particularly with COVID, we didn't have a lot of the testing sites in our neighborhoods. It wasn't until later on in the pandemic that they started putting these mobile sites into our neighborhoods. We also know that there's structural racism in our healthcare system. A lot of times when we go in with the same symptoms as our white counterparts, we're not given the same treatment. We're not given the same treatment options. So a lot of patients that I've come in contact during this COVID pandemic, they went in with their symptoms and they weren't even tested. I know in the beginning there was a limit on the number of COVID testing, but even after that, it still study shows that we got subpar treatment and not as much testing. And even the testing sites that we had, there were long waits, sometimes we have to think about too, just our healthcare facilities in our neighborhoods. A lot of times, unfortunately, we don't have a lot of primary care practices in our neighborhoods. We depend on urgent care clinics, emergency rooms, which isn't the best place for us to receive treatment.
Right. And I think that with respect to, all of the things that you just mentioned around access, testing, making sure that you have a healthcare provider, what's going on in our schools, what's going on in your workplace. We need to, I think, talk more about who needs to be tested. Obviously in New York, the pandemic, we have it somewhat under control with down about a 1% infection rate in terms of the number of people being tested. But we still need to be very, very vigilant and very careful. So in your opinion, who should be getting tested?
We're saying now that everybody should get tested, and particularly the population that really should get tested is if you've been exposed to someone, of someone who's had COVID and you've been around them. People that have coexisting conditions that put you more at risk for COVID, like hypertension, diabetes, respiratory medical conditions. And also, let's face it, I myself, I'm not always diligent about wearing my mask when I'm going out to brunch with my friends, for example. I was part of the protest. So if you might have put yourself in a situation where you might not have worn your mask or you went around a large group or large setting of people, again, make sure you get tested.
Right. And I think the other thing is that we all don't have the luxury to be in very large open spaces. So that, if you're living in an apartment with, a number of family members, and young children, and perhaps maybe you don't have pre-existing conditions like the ones that you mentioned, but you're over 65. I think even in that instance, it's very, very important to be tested.
Absolutely.
Let's go back to the issue of having a healthcare provider.
Yes.
And many of us use clinics. Sometimes we use the emergency department to get our health care. We really need to make sure that we have a trusted provider. What do we say to our community about making sure that you have access to a quality provider who can answer your questions and take the time that you need to understand the disease and understand the risks?
It's very important because, a lot of times when you go to these urgent care and emergency department, their goal is to get you in, get you fixed, get you out. It's not about the holistic care of the individual. So you really want to have a primary care provider that knows your history, that's seen you over the years, knows your medical conditions, and you build that rapport and that relationship.
Absolutely.
What do you think?
I totally agree with you. I think, when we look at structural racism, we need to be looking at the infrastructure in our community. And in other words, what are the resources that are there? Do we have primary care providers? Do we have specialists in our communities? And I think that if people are not satisfied with their provider, if you don't feel that person has a great bedside manner or is taking the time to sit down and talk to you and really sort of tap in to what's going on with you physically, it's time to leave that provider. And I really encourage people to really be in partnership with their doctors and to feel as though that they can trust their physicians. That's really important. And just as we were talking about it, not today, but certainly in past conversations, there are nurse practitioners and other types of providers that people can be going to in our community. And how about our schools? September is right around the corner.
Ooh, that's a hot topic.
It is a hot topic. And in fact, I was listening to a medical professional today. We thought that, children were not as impacted, and now we're finding that over 100,000 children are positive for the virus, and many schools that have opened have to close. So what are your thoughts about, the school?
And I just want to add on too that the recent studies have shown that kids are actually carrying higher loads of the virus too. So we got to think about that impact, because those children, even though they may not be showing any symptoms, they're bringing that virus back to the homes where they may be living with their parents and their grandparents. And again, that's a susceptible population that we're worried about.
Absolutely.
So,
and I think the argument that children won't use a mask is not correct. I have to say I have a 4-year-old, and sometimes he's more diligent about wearing a mask than I am. I think there's a way to explain to our children why we're wearing a mask, why we're social distancing. So I think that, when you're considering whether or not your child should return to school, it's really important to sort of tap in and connect with the school to find out what they're doing to keep your children safe at home.
Yeah.
So what other, in terms of testing now, so there are a lot more testing sites. Let's go back to that, right? There's almost over 600 testing sites in the city.
There are.
Do you know if there are any free testing sites?
There are free testing sites. And I always refer anyone who's looking for a testing site to really go on. I mean, even if you Google just New York City COVID-19, the New York State Department of Health has a great website where you can just put in your address and it'll list all of the testing sites. And a lot of them are free. So, we can get rid of that myth that you have to have insurance or you have to have money to get testing, because now they're readily available. There's testing to see if you have the virus, which is called the PCR test. And there's also tests to see if you have the antibodies, if you've been exposed to COVID in the past. And they're also making it easily accessible. I've seen testing sites in churches, barbershops. So I think that was, at least one of the positive steps I've seen in addressing the lack of testing in the communities of color.
Absolutely. And another resource is newyorkcity.gov. I myself used that as a resource and was able to get tested for free. And then also the New York City Health and Hospital Corporation. I think if you call 311, that's another really good resource for people to call as well.
Absolutely. So let's talk a little bit about what do you do if you find out that you're positive and you live, let's say, in a household where you have many family members living, in your apartment. What are some of the things we have to consider, what we want to tell our
Absolutely.
patients?
So, I am the Director for Hospice and Palliative Care at Visiting Nurse Service of New York. It's one of the largest home care organizations in the country, and you can get care at home. So, the thinking that, that means that you're going to automatically be hospitalized, that is not necessarily the case. I think that is another argument for being tested early so that your symptoms don't become so severe. So most of the times, if you're COVID positive and you're not experiencing severe respiratory symptoms or other related symptoms, you're really told to quarantine, to stay at home a minimum of 14 days. If you're unable to social distance, if you can work something out with your family members to, and suggest that, listen, this is a 1-bedroom apartment. I'm going to have to stay in my bedroom for 14 days and you're going to have to, camp out in the living room. So I think that really, is a bit of a myth that if I'm COVID positive, it means that I'm going to have severe illness. That in fact, that may only exist, I think, in 2 out of 10 cases. So it's like a 20% chance. Now, if you are hospitalized, then, there are a number of things that you could be doing to make sure that you stay in contact with your family, making sure that you have a cell phone, and I would say making sure that you have an advocate, a trusted friend or family member that can stay connected with you while you're in the hospital.
Yeah, and one of the things I want to particularly note for communities of color, they always say, well, you quarantine and just have people bring you food. But we got to think about sometimes in our community, we don't always have access to food, to have people that, willing to come over and provide food for you, or even being able to stay in your room, for 2 weeks. So I just want to address some of that. And one of it, I have to just tell a story that, when I first was working during the pandemic, I was redeployed to a COVID testing center. And I'll never forget, I was on the phone doing follow-up calls and I had to actually let people know that they had COVID. And I thought I was just going to call, you have COVID, this is what you look out for, you have the signs and symptoms, here's when you go to the hospital. But what I was finding was that people, they took the news of getting the COVID fine, but it was now you have to quarantine. Well, how am I going to get my food? How am I going to go to the doctor's office? I don't have transportation. How do I live in a place where I'm renting a room and I have other people who now know about my diagnosis and have kicked me out and told me I need to leave in the middle of having COVID.
Dr. Bryan, as you were mentioning, the emotional pressure that we're all facing, during this pandemic, the importance of staying connected, and getting support from family and friends. Now, what if I am a person who lives alone and perhaps, I don't have any family? Any recommendations for what, a person in that particular situation could do for themselves?
Yeah, so you think about, even if someone doesn't have family, are they connected to a church? Are they connected to, a senior center or some kind of other organization? Maybe they're neighbors. But I definitely want to stress that these are hard times, and we also have to think about people are really struggling with mental health issues. So knowing that, again, back to what you said, 311, there are resources out there.
That's an excellent point that you mentioned, that sometimes we don't always use the resources that are available in our community, and that there are numerous community-based organizations. If you call 311, that's a great way to find out about the organizations and how they might be able to help you, whether it's with food, whether it's with emotional support, or perhaps you don't have a physician and you feel like you have symptoms of COVID and you want to get tested. So why don't we leave our viewers with some recommendations?
Sounds good.
Let's talk a little bit about COVID symptoms. Now, as we learn more and more about the disease, we learn that, it impacts the body in many different ways. We do know that this is a respiratory virus and that it has a significant impact on the lungs. So if you have shortness of breath, coughing, sneezing, sore throat, heart palpitations, even now the gastric symptoms.
So there are new symptoms, and COVID, although respiratory, we're finding out that it's actually causing a lot of systemic problems also. So in addition to the symptoms that you discussed, yes, there's some people that have more of the, gastrointestinal type of symptoms, like the nausea, vomiting, diarrhea. And we also, one of the key symptoms that I particularly found when I was working in the COVID center was loss of taste of smell. Loss of taste or loss of your smell was definitely one of those symptoms that I heard from a lot of patients.
Right. So it's impacting our senses, it's impacting our neurological system, and we need to pay close attention to our children. We know that they oftentimes can carry the virus and may not show symptoms. And then sometimes in children, they get what's called the multi-inflammatory system impact. It's like a Kawasaki type disease that can really impact their heart. So please pay close attention to your children. And if you have any suspicion, and you should definitely have them tested as well. We recommend that if you have any of the pre-existing conditions that Dr. Bryan and I spoke about, whether you have hypertension, you have diabetes, or you have cardiovascular disease or cancer, you may be immunocompromised, please go and get tested.
Yeah. In addition to, I think there's a lot of fear of COVID, so a lot of people out there have stopped getting their preventative treatment, have stopped going to get their cancer screening. So just want to stress also, we're at a good point in New York. Not saying we're out of the woodworks, but we have a very low rate of COVID. We have much more education about COVID. So please start going back to your primary care providers, getting your tests done. Because, it's been a while. We want to make sure that people are still doing that kind of preventative care that they need.
Excellent advice, and get the right provider. If you feel like you cannot connect with your provider, he or she is not listening to you, they're too busy to really hone in on what you're saying, get a really good, high quality provider, and make sure that you continue to wear a mask, New Yorkers. We're not out of the woods now, or yet, and that you social distance.
At least 6 feet, and when you wear your mask, make sure you wear it properly. It doesn't count if you're wearing it under your chin. It doesn't count if you're not covering your nose. Make sure that you're fully covering your mouth and your nose when you're wearing your mask.
So take care, New Yorkers, and be well.
I'm very happy to be moderating this particular panel for two very distinguished physicians, two healers, and two people I've learned over the months that we've worked together on the COVID challenge, learned to respect and admire. First, I'd like to introduce Dr. Dean, Darwin Dean, MD, MS. Dr. Dean is a distinguished professor at City College, the New School of Medicine. He's a family physician who's worked in the community health centers in the Bronx and inner city Philadelphia for over 30 years. He's a graduate. He has a graduate degree in nutrition and pursued further training in mind-body medicine, meditation, lifestyle medicine, and acupuncture. Joining Dr. Dean today is Dr. Flora Leondo, a traditional Chinese medicine practitioner who is a New York State licensed acupuncturist, herbalist, and massage therapist. Dr. Leondo is bilingual in English and Spanish, and her mission is to provide Eastern and Western treatments to all those who seek to live a healthy and balanced lifestyle. We have been challenged over the last 6 months with responding to the worst pandemic seen on the planet in 100 years. The Greater Harlem Chamber of Commerce has taken the challenge to support the businesses and the people in the communities it serves. And luckily, we found a group of professionals to serve on our Uptown Leadership Health Committee to work on this issue intensively for the last 6 months. I'd like to start with Dr. Dean.
Good morning, and thank you, John, for that introduction. Over the years, I have been teaching nutrition to physicians and trying to help them to incorporate that into their medical practice. Western physicians are helping us mightily, as you've just heard from the staff at Harlem Hospital. This pandemic has had an incredible impact on our communities, but there's nothing that you can do to safeguard yourself. If you heard Dr. Wright's discussion this morning, he mentioned his bout with COVID. Now, this is a man who's dedicated his life to medicine. The question is, why did he get it? Well, he's right in the place where everybody around him, everybody he's taking care of, has the virus. So he has a high level of exposure. But he did not wind up in the hospital. He was sick for a few days and he got better. And that's what we'd like all of you to do. The question is not whether or not you're going to be exposed to this virus. While we are waiting for a vaccine, many of us will get exposed. In this community in particular, people still have to go to work. They still have to go out. They still have to do the things that will expose them to the virus. I've got a mask in my pocket. I wear it all the time, even though I'm not wearing it now on camera. We do all of the things that we know that we can do to try to prevent our exposure. But often that's not enough. So the question is, what do you do? We are here to try to help people to understand that you should not be afraid of this virus. You should not be afraid of other people. You should not be afraid of going outside, getting fresh air, getting sunlight. There are many things that each of us can do to improve our chances should we come down with or get exposed to the COVID virus. But the take-home message is, don't be afraid. Don't worry, because worry has a terrible toll on your immune system. If you worry, you have to learn to relax. Just 5 minutes of deep breathing. it doesn't have to take over your life, but do something good for your health every day. Dr. Leandro?
Yes. Very well said, Dr. Dean. My name is Dr. Flora Villando. I'm a traditional Chinese medicine herbalist. I truly believe that combining Western and Eastern medicine is a benefit for the community, especially here in Harlem. I've noticed in my office throughout the years that combining both theories has helped people tremendously. I've had the opportunity to work with people that have symptoms like of COVID-19 in my office. And what I've noticed, using herbs that have been around for 3,000 years has helped tremendously. COVID-19 is a respiratory issue and heart disease issues that affect the lungs with mucus. And I found combining Western and with traditional medicine, they have cleared their phlegm to no longer assisting it. Also, diet is very important. Diet is something that will boost your immune system. Anything alkaline, anything under 5.5 is acidic to your body. So I highly recommend the other brain, feed your other brain, which is your digestive system, the stomach. The stomach incorporates your body, mind, and spirit. And in the Eastern philosophy, we look at the body entirely, mentally, physically, and spiritually. And when you combine that together, it will heighten your spirituality as well as your respiratory system. And one of the things that I highly recommend is digestive system foods like cucumber. Cucumber is easily accessible, not expensive to the community, and it helps with high blood pressure, but it also reduces acidity in your body, which boosts your immune system. Along kale, it helps in blood circulation, reduces blood clots, and also, again, boosts your immune system to allow you to help with your respiratory system and breathing. Seeds like watermelon seeds, with watermelon, especially around this time, in the traditional Chinese medicine, viruses increase more during the seasons of the summer. We also like to recommend people to eat with the seasons, and due to the fact with mental disorders, suicide rates, it increases around COVID with fear. So we highly recommend people to eat cooling foods, such as vinegar with a little bit of water. Highly recommend alkaline water that is about 7.0%. Reducing red meats, reducing dairy to reduce the phlegm and the respiratory system. Combining both, I highly recommend. I've seen a big difference in my office. And when you work together, it's not which is better. It's about helping and making sure that we as a community work together with both philosophies.
And I'd just like to add to that, that what we're discovering increasingly is that whether you are looking at this from an Eastern medicine perspective or a Western medicine perspective, the conclusions are the same. So Dr. Leandro talked about the importance of digestion. We eat a diet in this country that does not have enough fiber. When you don't have enough fiber in your food, you starve your microbiome, the bacteria that live in your gut, and that contributes to inflammatory response. So when you get exposed to something like the virus, your body can't respond to it appropriately because you don't have the strength of all of the bacteria in your gut helping you. When Dr. Leandro talks about alkaline foods, all of the things that contribute to your microbiome are alkaline. The kale that she mentioned, whole grains, seeds and nuts. If we eat yogurt or fermented foods, sauerkraut, kimchi, you reestablish the flora in your gut, the bacteria in your gut. Those interact with your immune system and train it on a daily basis to not overreact. And the COVID virus is an overreaction. And that's what's putting people into the intensive care unit and making it so difficult for the physicians in the intensive care units to get people out of there, to clear the virus.
Yes, I would like to add to that. It also reduces inflammation. one of the things with COVID-19 is a lot of inflammation in your body. Antioxidants such as vitamin E and foods like cayenne peppers will reduce inflammation in your body. And if you can easily do that in your colorful food of plates, I tell all my patients to make sure that your plate is full of color. It helps reduce the radicals in your body, which are oxygen radicals that cause cancer as well. So you can do two things: reduce cancer-like cells and boost your immune system to reduce the COVID-19. You're a win-win situation.
So I don't want to give people the impression that we have proof that this will work. We don't. The studies are being done now. The virus is relatively new, but traditional Chinese medicine has a 3,000-year history of dealing with pandemics. Every 100 or 200 years, a pandemic came through. And because Chinese medicine has been around so long, they have a long experience of dealing with these things. Every infection is an interaction between a virus. In Western medicine, we call it the pathogen, or virus or bacteria, and the host, which is us. And in that dance, Western medicine is focusing mostly on the pathogen. We are looking for effective medications, we're looking for a vaccine, whereas the other way to look at that from lifestyle medicine, from the Eastern medicine perspective, is to look at the host. What are the things that we can do to make sure that our immune systems are prepared for whatever virus or pathogen comes down the pike?
Right. And speaking with Dr. Dean, I've noticed that when we work together, we're noticing that there is different methods and that you have different options for the community. It allows you to really focus on your health. I also recommend to my patients not only acupuncture, but activities that boost your immune system, like Tai Chi, that's been around for over 3,000 years. That helps with your breathing technique. It helps with your lung and heart. Also dancing, creativity to bring that back. It reduces fear as well.
So again, a little bit of daily exercise, whether it's going for a walk, whether it's dancing, do some deep breathing. Most of us do not breathe into our lower abdomens. In Chinese medicine, they call that dantian. There are all kinds of reasons why that's healthy for you. It helps to move things along in your intestine. When you breathe up into your chest, you're only using part of your breathing capacity, and it allows fluid to build up in your lungs. So taking deep breaths is very relaxing. It tells your body that you're not stressed out, that there's nothing dangerous happening.
I also like to recommend meditation. I would tell my patients in the morning, 5 minutes, not just to rush out and get out of bed, but it also reduces fear. It allows your body to mentally sink in with your mind, body, and spirit, and also lets your light digest them overnight to really sink in and think within your spirit. So meditation, Tai Chi, running, jogging, reduces fear as well. I highly recommend that as well.
So I think most of those are the issues that we wanted to touch on. We're going to let John Palmer ask us some questions and see where else we go.
Well, thank you for your words and your presentation. Listening to you always brings to mind how somebody who is listening to something for the first time becomes overwhelmed. When you have a lot of information and detail that are important to get across, the person who's listening to it for the first time or the second time all of a sudden starts to get overwhelmed, and internally they're starting to doubt that they can actually make the kinds of changes that you're indicating should be made, or they can understand the scope of dealing with an immune system versus a virus. How do you, each of you, recommend people make the mental switch that helps them open up and change the way they're thinking in terms of illness, health, and even the kinds of things you can do to become more healthy?
Well,
Go ahead.
well, First, I'd like to begin by allowing yourself to really awaken yourself by saying there are options. So reach out. Things that seem foreign, it's not foreign. Acupuncture. Try acupuncture. It helps with mental illness. It helps with fear. It helps reduce, and it also aligns blockages and it helps with the respiratory system. It's about opening up and being more open to other options and working with Western doctors. That's what I have here.
Yeah, and I know that it can seem overwhelming. I really have spent 30 years trying to tell my patients to work on their health, but always before I was telling them, if you don't do this, then eventually you will get a chronic disease. You will come up with diabetes. You will come up with high blood pressure. COVID has changed the timeline for that, right? It's not something now that will happen to you 10 years from now or 15 years from now. It's very immediate. You need to do things every single day to try to improve your health. And it doesn't matter which of the things you select. Pick something to work on this week. This week, work on doing some meditation. Next week, work on doing some exercise. Try to clean up your diet. My biggest frustration was that people eat for convenience. They eat because the food is inexpensive. And people think that it's too expensive to eat healthy. I can't afford organic food. We're not here telling you to do that. Eat greens, grow greens. Grow herbs on your windowsill. My wife and I have been eating garlic every single day, onions every single day. They're good for your immune system. To me, this is grandmother medicine. It's not really anything new. It's just taking better care of yourself. And so my advice to everyone is just think about your health. Think about something that you can do today to improve your health, and then do it.
Right, do it and be more open. Look at your body as a temple and look at it. I always tell my patients, do you want to be a Houthi or do you want to be a BMW? If you can put oil in your car, you can put water in the car, well, that's the same thing with your body and your system. Your body system is like a car. You put fluids in your body, you feed your body so that you can keep running, not just struggling to run, but to walk. Right, so take those options, look at other alternatives, chiropractor, yoga, meditation, Tai Chi. These things are helpful. Acupuncture is not painful at all. It aligns and opens up your blockage of anything that's blocked for years. It could be traumatic issues. So fear is the number one cause to not allow people to have options. So just take a risk.
Dr. Leandro mentioned Tai Chi and yoga. There are dozens of studies in the Western medical literature showing that Tai Chi and yoga help to reduce stress in the body. I just read a study last week showing that patients who had higher cortisol levels, cortisol is a stress hormone, patients who had higher cortisol levels tended to do worse when they were hospitalized with COVID. All of us can do things every single day to lower our cortisol levels. Just closing our eyes and breathing deeply for a few minutes will lower your cortisol levels. Yoga lowers your cortisol levels. Acupuncture lowers your cortisol levels. Meditation lowers your cortisol levels. Tai Chi, Qigong, lower your cortisol levels. Exercise lowers your cortisol levels. All of these things have a direct impact and an immediate impact on your immune system.
And I've seen it firsthand in my office. I feel sometimes here in America, people have to have scientific proof. But if things have worked over 3,000 or 4,000 years, like Ayurveda medicine as well, it's worked. It's worked over centuries. It's worked through my family lineage in Puerto Rico, where I come from, healers, where they go in the backyard, coconut water, oregano, palm trees, and do so many different things. And we have to remember to look at those times that food is medicine, and it does work. So if we combine those things together, I've seen it in my own office. I've seen people that they no longer need medication for mental illness anymore because they incorporated all that, the Western and Eastern, with mental stability, Qigong, to where maybe they even reduce the medication with a combination of herbs. So it does work. It doesn't have to be proven to scientific. I've seen it in our office where they no longer even have phlegm in their cutthroat or anger anymore because they're living the best life they choose to.
And while your physicians may not be familiar with herbal medicine, when I did my residency, Dr. Wright was talking about the 1980s. I graduated from residency in 1984. They taught us to use herbs as part of my residency training program. Herbal medicine has been around in the Western tradition for a long time, the Eastern tradition way, way longer. Herbs work. They contribute to your health, whether it's green tea or black tea or herb tea, thyme, oregano, parsley, basil, dandelion, all of these culinary herbs, things that we put into our food, help to make us healthier. And they will protect you from getting too sick from this virus.
The key is always to remember that you have options. Your temple, your body is mentally, physically, and spiritually, that you have choices, and combining Western and Eastern medicine can help you live a better and longer life.
We'd like you all to take charge of your health. Do something today to help your immune system to fight through this virus. Remember that you're not helpless, you're in charge. Whatever you do to make yourself healthy will help you not only in the long run, but in the short run.
Absolutely.
I'd like to thank both of you, Dr. Dean, Dr. Leander, for joining us today and opening up our minds to alternatives that we can use in combination to improve our health.
Thank you for having us.
Thank you, John.
I'm here with Jeffrey Lieberman. Jeffrey's chair of the Department of Psychiatry at Columbia University. He's also the psychiatrist chief for the State Psychiatric Institute and Columbia University, New York Presbyterian Hospital. He's specifically worked to help us improve our care of the schizophrenic patient, especially developing and help us develop novel therapeutic drugs and clinical care models for the early detection and prevention of schizophrenia. Our segment is mental health, and I think it's important to have Jeffrey here to discuss two events that have taken place and are simultaneously taking place in the life of COVID and mental health in the city. Some time ago, the United Nations declared mental health as a global pandemic as soon as it was clear the impact that COVID might have, or its potential impact. So that at this particular time, it's not a surprise that people are struggling to figure out what to do about the issue of mental health and COVID, what new programs can be developed, and what new insights we can gain into what we've learned already. Jeffrey and his crew have done some commendable work at New York Presbyterian and are becoming more creative and branching out to include Upper Manhattan and the West Bronx in the scope of the plans that they have. So I want to talk to Dr. Lieberman a little while about these particular issues, and then maybe something else again, if we have some time. The first issue is you are part of a mega institution, hospital that was hit by the COVID virus from Upper Manhattan, Washington Heights, the Bronx. I talked to some leading physicians at your institution. They were swamped, and the leadership, chiefs of staff that were working on the units. Almost nobody was spared from doing the kind of work that needed to be done because of the way your institution was hit. Could you talk a little bit about the impact of that initial, I'll call it attack, the kinds of issues and concerns your staff had, and how you responded internally, because that's one of the things that's most interesting in a minute. And I mentioned this not for dramatic effect, but just to remind everybody the tragic nature of the mental health issue was brought to bear when one of the physicians committed suicide, one of the emergency room physicians committed suicide.
Yeah, John, you've, I think, characterized the experience very well in terms of this was something that hit us out of the blue, and we were just initially overwhelmed. Because we're sitting far enough apart, I'm going to lower my mask because we're social distance in order to be able to speak a little more clearly. But the experience of the COVID pandemic and its impact on New York was like waiting for a hurricane that you heard about, but you didn't know if it was really going to come or how bad it was going to be. And then all of a sudden, it was on us. And to give you an idea of the rapidity, I was traveling throughout February to meetings and various other types of activities. On March 2nd, the first patient was admitted to New York Presbyterian. This was the lawyer who was from Westchester, who had been in Israel and came back and was infected, and he was admitted to the hospital. One patient on March 2nd. By March 15th, we had 200 patients. By April 15th, we had 2,000 patients with COVID. And by that time, in that process, we were all hands on deck. The main areas that were affected were the emergency room, the ICUs, and the medical units. But because the volume of patients that needed to be admitted and cared for life support reasons was so large that they had to convert a lot of the other floors or services in the hospital, like orthopedics, like neurology, like psychiatry, to convert them to medical units to accommodate them.
And just to let everybody understand what that means the patients that were usually going to use these beds were not able to get in these beds.
Exactly. Well, people that came to the emergency room were told to go home unless they were in a life-threatening situation. And there had to be kind of a rearranging of the deck chairs by the hospital leadership to be able to accommodate this flood of people that were coming in with the CoV-2, the SARS-CoV-2 virus. And we had never seen that particular kind of infection before. I mean, we thought it was a respiratory infection, but it proved to be something much more contagious and much different. And just to explain why it was so devastating, it's not so much that this virus was so lethal. It wasn't Ebola. It wasn't even AIDS. It was a bad flu. But the thing is that just like everybody eventually in their childhood gets the chicken pox or the measles, you don't all get it at the same time. Everybody was getting it at the same time because the virus went from a mammalian species to the human species in China, and then when it got out, it was the first time human beings had ever seen this virus, so their immune systems were not able to respond. So everybody that was exposed sufficiently got infected. Now, some people were mild, some people were more severe, but it was the numbers of people that was the real problem. It just overwhelmed the system. I'm happy to say that my colleagues responded heroically. I mean, this was like, man the lifeboats, all hands on deck. We've got a real emergency here. And while my department and my staff in psychiatry were not in the direct line of fire, we still had to deal with people in the emergency room who were having psychotic episodes, who were suicidal, who were drug overdosed or needed detoxification. And at the same time, we very quickly realized that the stress that this was having on the medical staff in the ICU and the emergency rooms was so great that all of a sudden we had another patient population. And we deployed a program of professional support and stress management that was going on daily for different employing groups around the clock to try and shore up their spirits and allow them to decompress. And it took...
And you're talking about staff, basically.
These are doctors, nurses, technicians, all of the staff that were needing to provide support services in the hospital. Now, doctors and nurses are tough. They're trained to deal with a lot of human suffering and long hours and everything. But this was beyond. This was like being in a field hospital in a combat zone. And the amount of death, usually there's a certain number of deaths from various illnesses per day. And so there was multiples. And it was just something that hadn't been seen in peacetime.
People would be surprised to know that on a usual normal day in the hospital, not a whole lot of people die.
Right.
We're talking about people dying in numbers.
But
But this had to be some sort of a shock to the system because my understanding was the deaths mounted every day in multiples.
exactly. You may have had, in a hospital, you may have maybe 10 deaths a day or something like that. In this case, there were hundreds. And my colleague, greatly respected and admired physician, Dr. Lorena Breen, who had not missed a day of work in 15 years, was a tower of strength and wisdom and dedicated clinician. It was just that sheer volume and burden of caring and the stress it had that overwhelmed her. And I don't know exactly what impelled her to take her life, but I assume it was because she was taught to care for people, be able to save people's lives, and she felt that she was up against something that she couldn't beat this one. This was just too overwhelming, and it's sad. So usually hospitals don't have ongoing professional support on a daily basis because people can handle it. They're trained to do that, but this required that. So a big part of our job as mental health providers was to help our colleagues as well as take care of the patients that we ordinarily do. Now, taking care of the patients we ordinarily do is made more complicated because if you have somebody that comes in that has a psychotic episode or is severely depressed and suicidal or is intoxicated by drugs, if they happen to be COVID positive, they're not necessarily following instructions like isolating in a room, wearing a mask, not touching people. So it became more challenging to manage the patients that we ordinarily would treat. And this lasted from mid-March to late April. And by late April, the governor, the mayor, the state and city had mobilized to determine what do we have to do to contain this. So the hospitals were really the front line, but then everybody else was told you need to wear masks, you need to shelter in place, you need to socially distance, you need to maintain sanitation and disinfect. And with this collective response, the rate of infection declined slowly but continuously. And thankfully, New York has been the model of the nation in having a containment of the virus, although it hasn't gone away, and there's the threat of its recurrence.
And in the comic books, there would be in the meantime, section, and now you say, what does that mean? Well, that means in the meantime, the people in the community were being told that there's a deadly virus afoot, and if they don't watch out, they were going to get it and die. And indeed, this was reinforced by the news that said, guess what? We've learned about a month later that Black and Hispanic people may be more at risk for this virus than other people. So they may die more quickly. And in fact, one of the biggest problems that they have is they live in crowded conditions and they have essential jobs. And so just in case you thought it was bad, now we're going to scare you half to death by telling you how bad it really is. So the no school, domestic violence taking a jump, gun violence now showing an impact from what we're seeing taking a jump. And there are complicated
measures that gun violence taking the joke. But one of those measures is economical. There are large drug gangs in this city that make a living every day. And if they can't get money out of the people who usually come and buy their wares, then they have to multitask. Sometimes they have to follow a Black Lives Matter group around and smash windows to get stuff out of certain stores, especially stores of a high-end nature, so they can have something to sell and then take something home. So in a small, encapsulated way, the chaos that was in the hospital that was overwhelming two professionals who then needed mental health care built more slowly in the community, because it's really hard to see all this stuff that's going on beyond your sight. And now we're seeing the kind of the ramifications of that. So in the face of that and the stress and the anxiety, I'm very familiar with the domestic violence side of this because I've been called into doing more and more of that work. We have, how did the idea for this comprehensive approach to mental health in the community, as this relates to the COVID influence, I'll call it, how did that develop, and how is it developing as we speak?
Well, you're absolutely right, John. The COVID virus stimulated a pandemic, which in turn stimulated social crises. And if New York City was the epicenter of the COVID pandemic when it hit the United States, the northern Manhattan section was ground zero. And it's not because people didn't follow the rules for social distancing and wearing masks, but people in Harlem, Washington Heights, Inwood, West Bronx, a lot of people were employed in positions that were non-healthcare essential workers. In other words, they were involved in transportation, they were involved in delivery, they were involved in supermarkets or stores and as clerks. And so they had to go to work. They couldn't shelter in place because they were essential, not healthcare, but everybody had to eat, everybody had to do various things to keep alive. And they also lived in multi-generational homes with young kids or elderly people. And so the risk of exposure was increased, and they were affected more intensely, more commonly than other demographic groups. So that created a disproportionate impact on different people within the city, and is now occurring really across the country. But then, as you said, we started out with one crisis, and now we have three. We had the COVID pandemic, but then we had the racial injustice events with George Floyd and in Atlanta that activated a response in terms of social protests. And then what has happened as a result of that in the pandemic, and is going to go on for a long time, is the social and economic disruption. And it's for this reason that we predict, and we have good evidence to support this prediction, that when there's a vaccine, when the virus has been wrestled to the ground, like the polio virus was, like AIDS was, there's going to be a long aftermath of psychiatric mental health problems because of the stress of the pandemic, but also the economic and social disruption. People are going to lose jobs, they're going to be economically deprived, their kids are not going to have been in school, and their education has been stalled. And you mentioned domestic violence. Domestic violence, drug abuse and overdoses, criminal violence, suicide, the incarceration, these are things that are the tips of the iceberg of mental health disturbances. And these are going to increase. So the normal population frequency for somebody who has anxiety disorder, somebody who has obsessive compulsive disorder, somebody has depression, somebody has substance abuse, these are going to rise. They're going to rise because of the effect.
They are rising.
And so in anticipation of this, while we were dealing with the surge, but then, there's an expression, Wayne Gretzky was a great hockey player, and a reporter asked him one time, how come you're so much better than everybody? He said, well, when I was young, my father said, you don't skate to where the puck is, you skate to where it's going to be. So we were looking down the road, and we said, wow, Northern Manhattan's been the most effective of the whole city. We're going to have a greater consequence in the aftermath. We should do something about that. And we began thinking about that. And in the phenomenon of great minds think alike, at the same time, community leaders reached out to us and said, we're anticipating our citizens being affected by mental health related problems. And we would like you to bring all of your brain power and expertise and tell us what we could do to preempt that. And we now are in the midst of developing and hoping be able to get the support to implement what we're calling the Northern Manhattan Mental Health Initiative.
How, well, I want to ask you how, because you don't know, but how quickly, yes, how quickly do you think you can pull this initiative together? Because rapidity is one of the things in mental health we sometimes lack and take years to respond to something. But this is a crisis of giant proportions. How quickly do you think you can pull together a response?
The ability to deploy this program is something that could be done within a matter of months. The rate limiting factor, I have to tell you, is really money and support. So what we've developed, and I won't bore you with going through it in detail, but basically would be the most innovative public mental health initiative ever undertaken. And I can say that it actually was inspired by the First Lady, Chirlane McCray, who undertook Project Thrive as such an initiative. But this even goes beyond that, because in response to a crisis, and it's being driven by some of the best minds in terms of public mental health that exist in the country. So what we would be doing is developing a 10-part program. The first part is to establish a body of expertise and services that are needed, and to take all of the community-based mental health clinics and engage them to work together and provide them with technical assistance as to what the state-of-the-art evidence-based services that are going to be needed by patients, clients, people when they come in. Secondly, we're going to develop a module to give to primary care physicians and clinics and to the school system to be able to use whenever the students come back and whenever people are seen by their primary care doctor. Third, we're going to provide an employment opportunity by recruiting individuals who are not healthcare professionals, not trained, probably mostly young, to become a community-based mental health corps. So these are people who don't have specialized training, but we're going to train them in mental health first aid. And we're going to then assign them to a specific neighborhoods to be the go-to individuals, to be the liaison for people that need help, to connect to the community organizations, whether it's churches, whether it's community centers, whether it's social clubs. Third, we're also going to create a module of tool-based toolkits and learning modules that we'll post on a website so that people in their homes who have access to the internet can download these things, watch them, which will provide guidance to them. And then in addition, because stories are powerful. And one of the great things about this program is that we're not talking just about wellness, and we're just not talking about mental illness, we're talking about the spectrum, because there'll be a spectrum of the way it affects people. So we're going to have a series of web-based town halls using Zoom or WebEx or some platform where we're going to practice narrative stories. We're going to have stories of COVID where people share what they've gone through. And then finally, we're going to communicate with the various computer technology companies, Google, Microsoft, Apple, because they're working on developing digital technology that can be downloaded to smartphones and used as auxiliary forms of assessment and support for this. And people will need guidance how to use it, but we can provide the technical assistance. We may not be able to buy the device for them, but we can provide the assistance of how to use these things. But the idea, John, is not just to wait for a person to come into a clinic or a doctor's office when they're suffering, but to go out and reach them, but not just a select number of individuals, to cover the whole population. This is a population-based approach, and it will be unique. And we will measure the effect of it, how it's reducing the rates of domestic violence, reducing the rates of suicide, reducing the rates of overdoses and crime. And if it's effective, it'll be a model to disseminate to the rest of the country.
Thank you. Sounds like a lot of work. Thank you for attending our COVID-19 summit today. I want to especially thank Greater Harlem Chamber of Commerce and the City College of New York for their role in the presentation of the summit.
Thank you for joining us today. We truly hope that you enjoyed the program. We wish to acknowledge and thank our partners in this endeavor: the City College of New York, Columbia University, Touro College of Osteopathic Medicine, Columbia University School of Nursing, Harlem Hospital Center, New York City Department of Health and Mental Hygiene, Columbia University Medical Center, the Visiting Nurse Service of New York Hospice and Palliative Care HOPE Program, the Anawan Wellness Center, and of course our speakers, moderator, and panelists. Thank you.